of you guys heard of community paramedicine before today? Okay, so we got a couple of hills to climb here. Good, because we can tell you everything that we want you to hear, and you don't have any preconceived notions, except for the folks that have raised their hand. You guys don't listen. So, history. Ambulance services have always been seen as a transportation service throughout the years. Except, lately, it started out with one protocol. If they were dead, you go to the funeral home. If they were alive, you go to the hospital. It was all run by hearses. There's a few people in here that are of an age that can remember this. Then somebody said, why don't we get a little first aid training for these hearse drivers? And on occasion, we can help somebody make it to the hospital a little more often than the funeral home. Then that evolved into, let's officially train people, get them certified, checked off by the agencies that can deem they know what they're doing, and try to save people first, and then if they need to go to the funeral home, we'll deal with that later. So that's where we are now. So what used to be a transportation service that, oh, by the way, we'll put some Band-Aids on, see if we can help you, is now a service that is a medical provider, healthcare service that also happens to ride transport. So we've flipped that whole coin on that. The evolution has continued. I'm not going to tell you about what every one of these things does, but I'm sure you're familiar with the term flight medic and combat medic and all these other things. Today is about community paramedics. That's an oddball one that is very new, that people don't really understand what it is. So community paramedicine, the whole concept is we try to intervene before the next 911 call. Now you may have called 10 times this year already, but we're going to try to figure out what to do to prevent that next one. So if we can identify you as at risk, either through a hospital discharge coordinator, through a physician, through a firefighter that happens to see you on the scene somewhere and say, this guy needs some help or we're going to have trouble. A PCP. Sometimes the patient, I've had patients call and say, I heard you had this program that helps people, and they don't know what they're asking for, but once you investigate, you find out. So we get referrals from all over. Quite often it's a medic that just walks in and says, there's something not right here. I don't have the time, because paramedics have a job. Their job is respond when the bell goes off. You get there, you identify the problem, stabilize the problem, give the problem to the next level, and then you're on your way. It's very frustrating for a lot of paramedics to not be able to spend more time to say, I know what caused that problem, let me fix it, let me work on that. So they hand that information off to the ER or to wherever they go, and they hope somebody follows through on it. The ER is always quiet enough, nobody's very busy, so they can always follow through on it, right? So it's a frustrating thing, because that medic will go back time and again and see the same things and not be able to. So for a long time, smaller communities, and even some larger ones, but they've been doing community paramedicine. They just didn't call it that. They called it taking care of our neighbors. And so if you lived somewhere that was one of the best examples of this, I met some guys from West Texas, and their closest hospital was about 200 miles away. And so the local ambulance service, which was not run out of the firehouse, but it was a standalone service, became the de facto clinic, emergency center, or whatever, that they would have almost as many people drive up to their service as they would get called to go to their place. So they were doing this. Or if they didn't hear from Aunt Booty or Uncle Booty for a while, they'd say, well, let's go check on them, because they were sick before, let's go double check. So this has been going on, but finally it has kind of coalesced into something we do call community paramedicine, in that we are identifying, as you guys said, the goals, the problems, the barriers to health, those things. How do we remove those so these people do not turn into that next emergency, whether it's a 30-day readmission, whether it's a high utilizer in the ER, or whatever. So very briefly, and then we're going to move on and let everybody talk about their programs, so that everyone that's here can listen to what's in your area and decide what you need. Also, keep in mind, this microphone can make it sound like I'm the only one supposed to talk. Please shout out questions, raise your hands, or whatever. In 2015, just a very few years ago, the legislature, and Gerald can tell you more about this because he was on the front end of it, some of these other guys were, but they really worked hard to make people understand that this is a valuable asset for people. money-wise, but also just the quality of life people can have. So they worked very hard at putting through some legislation that said community paramedics can exist. As you can imagine, the idea that we would go out and see people on a non-emergent basis and go try to find out what their problems are, work with those problems at home and keep them in the home, might threaten certain agencies and certain groups that already do that. So we decided that we needed to have those people at the table when we did this, to make them understand that we are not gonna be here to take anyone else's job and step on anyone else's toes. We wanna fill the gaps that you guys can't get. We want to bridge those caverns that patients are slipping through. So we had all of these folks here, the home health, American Medical Association, public health, lawyers, the lobbyists for home health, all these folks were there, and there was a lot of discussion about what our scope of practice was. Should it be expanded? Are we staying within our scope of practice? Who has authority over us? All of those things. On February 1st, after all the discussing and cussing and everything, we developed the rules regs. Governor signed it in February 1st. We had that adopted, and on February 13th or something, Mountain Home, where Gerald is from, that we keep talking about, we're gonna meet him in a minute. Their first 3 state licenses were issued to 3 of their medics. It's a very big thing, because that was the birth in Arkansas of this whole industry. And they had already been proving over the years that it was a very valuable thing. So what it takes to be a community paramedic is experience, at least 2 years. Then you have to be the right person, the right personality. You are chosen by the folks who are trying to run the program, and they know what they're looking for. Then that medic goes back to school for an additional 310 hours. It's 100 hours in the classroom, 210 hours with you guys. Okay? Case managers, social workers, public health clinics, doctors' offices, ER extended time, labs, things like that. All these things that paramedics don't usually have to deal with because they've got a 40-minute contact with a patient. Not a big deal. So we had to learn a lot of these extended processes, extended thought things to develop plans of care for the patient. And then I just want to point out this one thing here. You will hear all of us probably mention funding has always been the issue. Insurance companies don't know what to do with us. The value is there. They understand it logically, but when it comes time to looking at a bottom line and saying, if I pay you this amount of money in a year, I'm gonna save this amount of money. Well, that's not a bottom line that a CFO can see in a quarterly report, so it's very hard to get on board with that. So you have to do a lot of data collection and kind of force it to them. Typical services, you can read this. We don't all do all of this. We do what our community is called for. It's called community paramedicine. One of the first things you do is assessment of your own community. What do you need? One area of the state may need more elder care concerns. Another area of the state may have more pediatric or more low income, maybe more navigation of services rather than direct medical care. So we have this and many other options. And the neat thing about being such a new industry is pretty much every year we're talking with each other in the health department and deciding where does it need to grow, what's the most important place to put it. If you guys are already covering it, we don't need to do it. So we're looking at where's the next hole. Now, some of you said you've heard of our programs, you understand what they are. Every one of us is going to tell you something about our own program. You're going to hear some duplicate and some overlap. And by the time they get finished, I'm going to probably just stand up and say ditto. But I want you to listen to the folks where they're from and in your area. Speak up, ask questions. This is your time. Afterwards, if we have time, we will have a round table, and you guys can ask then, but don't hesitate to interrupt and ask your community member. Yes, ma'am.
Ed, is there any conversations going on with Medicaid or with?
Absolutely, I can mention that. There are a few insurance companies understand it, they get it. In fact, even in the ACT coalitions, we were approached by Humana and tried to work up a 5-state agreement, or a 5-company agreement in 3 different states to do this. They kind of got hung up on the billing process and things like that. The difficulty for us is there's not a billing code for an ambulance service to not transport. We get paid for transport. If you crash your car and have a heart attack, the 4 of us, 5 of us will go out there, we will save your life, we will give you all the drugs we got, we'll put tourniquets on, we'll do surgery in the field and all kinds of things. And then we're gonna put you on that helicopter, and none of our ambulance service is gonna get paid, because what we get paid for is transport. That is the difference right now, is ambulance service is seen the same as a DME company. It's a service type provider. It's not a medical provider. And so as we keep continuing to flip that coin into the we provide medical service and we also transport, that's where they're starting to understand. So yes, to answer your question, the Blue Cross just came out with a discussion that they're going to investigate doing a treat and refer type process, where if you do treatment on the scene, it's appropriate treatment. You do not transport CMS, okay, and you do not transport that person appropriately to not be transported, then you can still be paid, or you can transport them somewhere else. The state says paramedics have to transport to an appropriate facility. Insurance companies say, we're not gonna pay you unless you go to an ER. So does that kind of cut their own throat by saying, take them to the most expensive healthcare doors in the system, or we're not gonna pay you? What's my incentive to not transport that person? They're comfortable, they're in my ambulance, they don't need to go, but they want to, hey, I'm not gonna talk them out of it. So, yeah, now they're starting to realize that. Medicaid has actually entered into some discussions too on how they can do a treat and refer. And Gerald might touch on that when he gets up here, because we had some discussions with the Medicaid office. I don't want to take any more time because these guys have got some things to say. What other questions for the opening right now? Please be interactive. Ask these guys things. Try to stump them. They,
All right.
Anybody but Ronnie.
So, without further ado, Battalion Chief Ronnie Crupper. He is from Bella Vista. He is the director of their program. And he's going to give you an overview of what they do. And Ronnie, there you go.
I was blinded by the light. Yeah, I'm excited to be here today and talk a little bit about our program. We're a little bit different than Ed, and Gerald, and Jason. We're a fire-based service. We're also a municipality, so everything we do is funded by tax dollars. So we have to answer to a mayor and a city council anytime we want to spend money on anything other than fire trucks and ambulances. So that's a big hurdle for us. And we were lucky enough to get a corporate grant through Mercy. She was sitting there earlier. So we started out with a grant through Mercy. They facilitated the grant through the Blue and You Foundation. So with it, we figured the best way for us to get in people's homes and talk to them about community paramedicine, because at the time, this is back in 2015, there wasn't even a license for it in the state yet, and nobody really knew what it was, including us. We just knew we wanted to do it. So we put some guys through school through UAMS, and we took the rest of the money and we bought smoke detectors and batteries and CO detectors and fire extinguishers. And what the Mercy nurses would do is they would ask patients with chronic illnesses if they would like their smoke detectors checked when they got home, and of course they'd say yes. So we'd show up and we'd change their smoke detectors for them and do batteries and CO and do a little home safety inspection. And then we would talk to them about their illness. We would say, hey, could we take a look at your discharge instructions and go over your medications with you and talk to you about your diet and make sure you understand your illness and the medications you're taking. And they would say, well, we thought you were just going to change our smoke detectors. We're like, I got you. And then we'd sit down and get to hang out and spend some time with them. And that's kind of how our program started out. As it progressed throughout the state, we were lucky enough to get in touch with Ed, Gerald, and we all determined that it would be smart if we all worked together, because we weren't in competition. We wanted this to work in the state. So we started a subcommittee for the GAC, and we get together every once in a while and we share information and we trade emails. And Ed, I sent an email to Ed yesterday. I got an email about the thing with Medicare was maybe get a due and give us some money. and I sent it to him. He's like, yeah, I got this from 4 other people already. And so we've been really good about sharing information with each other. And it's really progressed over the past few years into a really viable program that's having great success with Baxter and Men's and even up in Bella Vista. Just a real quick overview of our program. We have a really unique demographic in Bella Vista. We call it the land of the newlyweds and nearly deads. And it is because it started out as a retirement community, so all these people are getting to be like 140 years old. And when they die, then young families are moving in. They're coming in Northwest Arkansas to work for Walmart, J.D. Hunt, and Tyson. So we have a demographic of really young families with babies. Oh, I'm sorry.
We put your reminders there.
How's this? Okay. So I'm not talking about any of that. Anyway, so we have a lot of elderly people. Bella Vista was a retirement community. People come from mostly northern states. A lot of Minnesota, Iowa, and being a Razorback fan, you know that if the Razorback game's on, they're going to call 911. If Nebraska's playing, nobody calls. It's exhausting because they don't care. But we do have a lot of elderly, and what's happening is their spouses are dying. So now they're at home alone with no support network. Their kids live in Nebraska. So really all they have is their neighbors and the community to help them out. So having a community paramedic program for us is very important to be able to provide those resources, address those social determinants, and keep people out of the hospital. So I'm not going to go on any further about that. I'm going to turn it over to, who's next? Gerald. All right. If y'all have any questions, we'll be over here afterwards. Thank you for your time.
All right, well, thank you. Melody, thanks for inviting us. So, let me give you a little bit of history about who I am. I'm actually I'm a RN paramedic. I've worked at Baxter Regional for about 44 years. Today, y'all passed around a sign-up sheet somewhere, and it was asking information about male, female, and all those other things, and I just happened to have I rode down here today with my daughter-in-law, Michelle Sharp, and she said, I don't even know how old you are, and I told her, and she went, oh, jeez. So I went, oh, crap. So Ed mentioned early on about somebody running out of a hearse. My very first ambulance call, I've been running on an ambulance for about 44 years now. My very first ambulance call was in a red and white hearse, so thanks, Ed. So Baxter Regional Medical Center. We're in north central Arkansas. We cover actually 2 counties primarily, but a 3rd county as well, Baxter County, Marion County, and also into Fulton County. And when I say we cover, we actually have our community paramedics seeing patients in those 3 demographic areas. So in that area, of course, we're very rural. We have a unique situation in Arkansas, probably in the United States. We live in a retirement community where 70% of our population is over the age of 65. So that puts them in a position where our hospital is actually very, very vulnerable to changes in CMS guidelines. And when they change things on Medicare, it really adversely affects our hospital. So that was really kind of where we began having conversations about community paramedicine. Why is it important that we do something like this? Primarily because now all of us are talking about readmissions and penalties and all those things. So having been in healthcare for 40 plus years, all of us sitting in this room probably could have the same conversation. We don't understand the healthcare process right now very well at all, with all the changes in Medicare and everything else. So if we don't understand it as the healthcare professionals, our patients certainly don't understand all the changes they go through. Hence the slide here. And that's really where we come in, is we really try to become a conduit for our patients that are leaving the hospital that have very, very challenging situations going into the home setting. They're very confused about what just happened in the hospital. Now we're sending them home. They're really, really sick. And now they're trying to figure out, what am I going to do? That's where we began the process of having a conversation about, hey, we could do something to affect this and change the course of what EMS looks like in the future. So that's where our conversations began. So why did we begin the program? We're a hospital-based ambulance service, so we have a direct relationship with the hospital. We understand very closely about what the hospital's dynamic is. We have a large number of patients, as do all of these other guys that are running on ambulances. We have a lot of patients that are utilizing our services frequently over and over and over and over again. And not only are they using the ambulance service, we're bringing those patients to the emergency room. So as we started looking at, hey, what can we do to affect some of the things that are happening with CMS? One of the things we saw very early was we have patients that are using the ambulance 50, 60, 70 times in a year, but when they use us, more than likely they're going to the emergency room as well. So they're high utilizers of services. So we began poking at that to begin with, and very shortly, in 2012, moving into 2013, our administrative staff started saying, hey, while you're doing that and you're having some really good success trying to manage those patients, we're starting to see some issues with CMS, and they're saying, hey, your readmission rates are really, really high. We're going to start penalizing you for allowing these patients to return back to the hospital in a short period of time. So along with that, a lot of the patients that are high risk, even now, we saw were being discharged without any services as they go into the home setting. A lot of our patients, a lot of the patients that, for those of you that are hospital services, a lot of the patients that leave the hospital for one reason or another may not be eligible for other services such as home health and those other services. Ed mentioned about filling the gaps. Well, that's why we began having the conversation. Hey, what could we do to affect that patient that's going home and getting into the home setting, but nobody's helping them manage their health outside of the walls of our hospital? What can we do to affect that? So as we began poking at that a little bit, we realized that we had some value not only to those patients, but also to our hospital. So why community paramedic programs? I've talked about a few of them. We provide services to these patients that otherwise would not have any services. Readmissions are a big deal these days. In 2013, they were a great big deal for the hospital in Baxter Regional. Again, 70% of our patient population was Medicare, and a large percentage of those patients had a lot of those comorbid conditions that we've been talking about: CHF, pneumonia, AMI, COPD, things of that nature. And they fell into that bucket of penalties that the hospital was initially seeing. The high utilizers of ER services were an issue. We realized as these patients were going home that if nobody's managing in the home setting, our primary care docs probably have no clue what's happening to those patients outside of the hospital or outside of their clinics. So we began affiliating with them and saying, hey, how can we help in that way? The other thing that we did was we really approached our hospital and said, irrespective of anything else that we did, these patients deserve more than what they're getting right now, and we do it because it's the right thing to do. So how does our community paramedic program work? Well, we receive referrals from our primary care docs, from case managers, from home health agencies. Some of the home health agencies that we partner with up in that area have patients that either are being discharged from their service, or maybe they're having issues with managing that patient, and we partner with those folks and go into the home setting at their invitation. We never go into the home with home health if home health is already there, unless they invite us there. And then again, once we receive those referrals, not only from primary care, case management, ER, and our EMS service, we have a large patient population of I've fallen and can't get up patients. We go out and see those patients on a regular basis, trying to keep them from becoming a statistic, a lot of times in the trauma system, where they've fallen and broken their hip. When we enroll a patient in our program, if they're a high high-risk readmission patient, we enroll them for at least 30 waiting days in our program and try to manage them to keep them out of the hospital. ER patients, what we call our HUGS patients, the high utilizer group, we'll see them for 90 days. Those patients are really challenging. They're hard to find sometimes. And sometimes they don't understand the whole healthcare system as a whole. A lot of times they've ran past their allowable office visits, or they may have terminated a relationship with the physician, so they don't have a primary care doc. So we're seeing those patients, but if we see them, we usually enroll them in our program for 90 days and do everything we can to help manage to keep them, not only from calling the ambulance, but we try to keep them out of the emergency room as well. So Ed spoke of early on about, as he was talking about services. When we started our program in 2012, there was absolutely no funding available. We hadn't had any conversations. In 2013, we talked to our hospital, hey, we think we can do this. How can we move this forward? The hospital funded our program to begin with. Through the process, we got very, very lucky in 2015 and 2016, received a very substantial grant from the Blue and You Foundation that helped support our program for 2 years. Now, since that time, we began having some business relationships with payers. Ed spoke of a couple of 2 or 3 payers in the state that express interest and have a limited knowledge of our program. So the payers in the state, the insurances, Pam mentioned earlier about Medicaid, they're all beginning to have conversations about, hey, we see the value, how can we connect with this program to try to help redirect and help manage our patients in a little bit better way. Our goal has always been do everything we can to help those patients that are falling through the gaps. We continue to do that. The other thing that we've added to it as a component of our program, which is kind of neat, we do a telemedicine program with particularly our high-risk patients. In 2017, we received a pretty substantial grant for telemedicine through the USDA, and we implement that, and it's been very, very successful at helping us proactively manage those patients outside of the hospital setting. So that's all I'll say. I say, just like Ed did, if you have questions, we'll be glad to answer them at any point in time. And I think Chris is next. Jason, I'm sorry.
So I am not tech savvy, so. Hey, there we go. All right, so number one, I don't know why I drew following the headliner, but so the other interesting thing in all this is all 3 of these guys wanted to start their program. When I was asked to start a program, I said no. I said no, I didn't want to have anything to do with that. I've been a medic for 25 years. I don't want anything to do with it at all. Slowly but surely, my boss, Brian, kept on, and he's like, come on, I really want you to start this, I really want you to start this. And so I'm like, okay, fine. But we have 2 things. I said, number one, I'll start it, but I need to know who's in charge. I said, if you're in charge, then I'm not going to run it. If I'm in charge, then I'll run it. And he said, yes, you're in charge. However, if it fails, it's on you. Which I was okay with, because then if it fails, it really is me. It's not somebody else telling me what to do. So we started out a lot differently than some of the others. When we were asked to start our program, we kind of were looking at readmits, we were looking at high utilizers, and honestly, I thought our focus was going to be high utilizers. But our administration came in and they said, hey, we have this doctor who's really interested in doing some chronic care stuff, and he really wants you to work with him. And so we're like, okay. So it was a whole new kind of thought process for us. So what we actually did, we got with one physician. He picked his top 25 patients who he thought over the next 6 months, without any interventions in the home whatsoever, were going to become those HUGS patients, otherwise known as the frequent flyer. We like the HUGS better, it sounds better. Or they're going to start readmitting. And so we said, okay, we'll take your top 25. The cool thing was, he invited us into the appointment. He introduced us. He said, this is Jason. He's going to be a part of this. He's going to work with me specifically. He's an extension of me. What he says goes. So listen to him. And so we instantly had that extra support. So they're like, well, my doctor says it's okay. It's got to be okay, right? So we started in the home on these 25 patients. But what we learned really quickly was, I'm that guy. I'm that swoop in, take them for 20 minutes, drop them off at the hospital, and I am on to my next thing, and I don't care what happened to that patient after that. And I know that sounds terrible, but it was the only mindset I'd had for such a long time. Well, now I can't do that anymore. So we start learning these disease processes, and now I'm like, okay, now I'm going deeper and deeper. You know, we talk about HF and we talk about COPD. Well, let's get them an IV, let's give them albuterol, let's give them solumedrol, and let's give them the ER. No, let's work on through this. How do we fix this? How do we stop? Oh, what's that bag of Doritos sitting there by your chair? You know, let's get rid of that. Lay's, you know, those kind of things. And so we started learning that process first, and it was really cool because we built up credibility with our physicians, number one, because then this physician starts talking to the other physicians. So as we moved into readmits, we already had some credibility with the physicians, to the point where it became where we would walk in the back door. We never went through the front anymore. Our physicians were giving us their cell phones. We were able to call straight to them. They would step out of where they were at to talk to us. And so it worked out really well. We've seen a lot of good success with that. But what we did is we did resource management. We did home health care to a point, because these people weren't receiving those kind of services yet from home health. And as they proceeded on, we would refer them to anything from hospice to home health to, oh, hey, I think we need to look at some long-term placement, and we worked with the physicians through that. So that was really cool. So that's kind of an overview of what we kind of do. We do a lot of home health, and I always, when I first started talking to patients, it's like, we are home health for patients who don't qualify for home health. It's the easiest way to do it. It sounds much better than the crack fillers. So, and that's the other part. Tough crowd. I was hoping you'd laugh a little more on that one. Woo! So, but as we moved on, then we started going after the readmit patients. And actually, frequent utilizers, or HUGS patients, was really where our CEO and our administration wanted to start. It was actually the last thing we actually got into, and we've only recently done that, and I'll share a little bit of that. But our readmit patients, the cool thing with that is we started looking at readmits. So we got involved right away with case management. So every day I sit in a case management and social worker meeting every single morning at 10 a.m. And we go through the whole entire census and talk about everything that's going on with every single patient. And so then we're able to build that rapport with them. If they identify a patient that's going to be probably a community paramedic patient because they don't have any other resources, they're not going to qualify, we go meet them in the room and we go talk to them there. Because there's nothing worse than just getting out of the hospital and getting a cold call from somebody that says, hey, my name's Jason, I'm with community paramedics, and you're with who? And what are you selling? That's the only things they care about. And so we were able to kind of build that too and build some rapport with them prior to that. So that was really cool. And then as we started in on this, what we found was we still had all these chronic patients that were calling us pretty regular. And they have our cell phones, we give them to them. It's our choice whether we do, but we get calls all the time, and I take calls on vacation, I take calls in the middle of the night, still do. And that's okay, that's the service I provide. Everybody's different, so we all take different tacks with it, and this is the way we chose to do ours. But as our readmits kind of became more of our focus, we identified those chronics that we were still seeing, but we've been working with them a while, they're getting better, so we decreased visit levels with them. Now maybe we're only seeing them once a month. I have myself and another full-time community paramedic, and we see basically 70 patients every month. Now, some of those are auto revolving, and others are in for 30 days and out. But we run about 70 patients. Our readmit rate's about 85%. Our goal was always 90 to 95%, keeping them out 31 days on readmission rates. But what we found was we were going to be satisfied with 85%, because 85% is still better than 75%. Or 65 or whatever, and we don't turn down a referral. So the chronic COPDer that's in all the time because he smokes all the time and he does all these other things and he's not willing to listen to anyone, and he's still not going to qualify for home health, they're going to send him to me on a referral, and we're going to say, sure, we'll go in there and we'll do it. Because if I stop him every other one, now I've at least done some savings there, and there's cost savings, and there's value in that, and there's education, and they start to get it eventually. So hopefully our goal is to get it up to about 90%. Right now, like I said, we're running about 85%. I want to knock that over. So then we started moving into frequent ER utilizers last. We are just very, very early on in the stages of this. We've developed a program with our ER director, and they're actually, we create a list and we go through and we have kind of a top 25, top 50 list of ER utilizers, and we do it every quarter. We run it every quarter, we compare every quarter, we compare to last year. And so if those patients come to the emergency room during any of the times when we're in the offices, they call us. And then our goal is to get down to the ER before they leave, and the emergency physician will actually walk in with us, introduce us to the patient and say, hey, I think this guy or this gal can really help you with some of the things that you've been struggling with. Now, some of them are there, and we have to get, and when we get in the home, then we have to identify what is it that they're taking away? What is it that makes them come back to the emergency room? Because let's face it, I've been in there, I know what it's like, picking up the same person 20 times in a month. I don't know why they come back, because it can be brutal. Nobody wants you there. They don't like you there all the time, and we can be truthful about that and say, how many times does we say, oh, it's him again, oh, it's them again? They don't want to come there just to be abused. There's something they are getting out of that emergency room visit no matter what. So we seek out what that is. Whether it's they got great coffee, maybe they run out of food. When we first started our program, we visited with Gerald and his team, and they talked about a patient who lived close to a gas station. That was the only thing he had for food, was go to get gas station food. And so by the end of the month, he's out of food. Well, if I go to the hospital, they'll feed me. If I tell them I haven't ate, they're going to bring me up a tray. So what do? You come in and they get food. So again, it's figuring out what those needs are, and that's a big part of what we do. We try to find those needs. Because what we found is the social workers can go in and they can go into the room and they can talk to them, and then the patient will say this, this, and this, because they're embarrassed to tell you that they live without running water, or they don't have any kind of heat source, or some of the other things. They're proud people, especially in our area. We're very rural. They're very proud, and they don't want you to know. They don't want you to know their business, number one. But once we build some rapport, they're actually willing to open up and say, this is really what I need. So then we go find those needs, and we help them find the resources to do that. Along with working with our social workers and that, we actually work very tightly with our population health department. So we're looking at expanding into telehealth, not only where we're going to these rural patients who are way out in the middle of the sticks, and I mean some way in the sticks of Newton County. If y'all know where Newton County is, it's along the Buffalo River, and it's very, very rural. And so we have patients there who have no way to get to the hospital. They have no way to get to their doctors. They're not going to follow up. They're very private people. So we're looking at a telehealth program where we'll actually go out and see them, and then we'll, use an iPad and FaceTime back in with the physicians or their nurse practitioners and try to bridge those gaps of care before they really, really crash and burn. And so we're working through that. We're building very much a team concept where, 2 weeks ago, I took the pharmacist out with me to a patient. She didn't understand her meds. So we went out and said, hey, you want to ride with me? We went out. The pharmacist took my patient and sits there and starts going over all the meds, and I sat with the grandson and watched Transylvania. So, Hotel Transylvania 3, I mean, what the heck? I play cars, but we did whatever was necessary for that patient, and I've heard several of us, and I believe we all feel the same way. We got to do whatever is right, whatever is necessary, and whatever is needed. So with that, I'm going to step out, and if y'all have lots of questions, Ed's going to come up and kind of wrap, and then go from there.
so far from these speakers yet? Okay. Glad you've absorbed everything and it's crystal clear. Couple of things that I really don't have a lot to add. I told you I'd probably just get up here and say ditto, and I can almost do that. A couple of things I want to point out that I've been trying to keep track of what hasn't been. One is the different services that are providing this. And the interesting part of this and the exciting part of this in our state is you have hospital-based services that have a certain concern about a certain population and what their financial concern is, what their population health concern is, or whatever. You have a fire-based service, which is tax-supported, covers a certain geography, has a certain reporting mechanism of who they have to answer to that's different than a hospital administrator. You have MEMS. Just so you guys know, it's Metropolitan Emergency Medical Services. A lot of people say, what does that stand for? Training costs got to be way too much, so we shortened it. But our position is slightly different than this in that we are sort of like Switzerland. We don't have a single hospital system or a single municipality that we are beholden to, that we get our guidance, our assistance, or our directives from. We, very briefly so you'll understand, MEMS Ambulance Service is an ambulance authority. It's like the airport. We get no tax money support. We get governed by a board of directors. The city oversees that and says, here are the parameters that we want our ambulance service to be for the city. Who wants to do it? MEMS came in 187 years ago, it seems, and we said, we'll do it. And over the last 34 years, it has grown and developed into what it is today. It started with 3 ambulances. There are rules that have to be maintained. The part of that that makes it not so easy is they said, don't ever come back and ask for tax money because you're not going to get any. You have to build your company within these bounds. You have to take care of it, have to maintain it at a certain advanced life support level, respond to minutes or less, 90% of the time, yada, 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 and you have to pay for it. So that's why we have, one good thing is the luxury that we have an exclusive contract for the areas we serve, because the expensive part is the emergency. When you turn the lights and sirens on, you're losing money. When you do a transfer from hospital to nursing home, you're going to get paid. So if you don't get all of that, you can't afford to keep your service going. So we've been very fortunate that we've been able to maintain both of those, and the cities and communities that we serve have been helpful with that. That has allowed us to grow and become a pretty large service, 2,200 square miles. We cover 3 full counties, part of Lone Oak County and a little bit of Saline County, about 550,000 people, and we've been doing that for a long time. And as a result, the reason we got into community paramedicine is it was kind of developing in areas around the country, and there had been talk about the legislation and different things, and I was doing work at St. Vincent at the time. I was in a management position there, and I had just left, and they called and said, hey, you helped start MEMS a lot of years ago, paramedic for a long time, been a nurse for a long time. We think you're in a good position to help us build a program. We're not sure exactly what it is, but we want one, because if we don't do it, somebody's gonna come in and tell us how to do it. So I went and visited with the folks who had already started it and realized that we could do this in Little Rock. The difference is that we had to take it all out of our own pocket and decide if we could. And the fortunate part of this is MEMS, as the largest in the state, like it or not, it's like Walmart. You either love it or you don't. There is some jealousies. There are some people who love what MEMS does. There's some people who think that we're too big for our britches. The bottom line is we have a responsibility, as Jason said, that this is the thing that our community deserves. If we can afford to do it, we should. So we did. When I asked Mr. Swanson, our executive director, about what kind of triggered this, he said, well, they started looking at their data, and they realized that just one example was they had 3 patients in 1 year. They constituted 222 ambulance calls to be transported to the same facility. Now, I know you guys have never heard of anything like that. Never had this? Yeah. So that got my attention. He said, can you build us one? And I said, sure I can. said, all right, you're hired, go to it. I locked myself in the office, and for 3 months, I tried to figure out what the hell it was. And it was very fortunate. I spent a lot of time with Gerald, because they were pretty much the only ones that had 2 feet on the ground that had been doing it. And he steered me in a lot of good directions with some mistakes they had run into, some barriers they had to overcome, some successes they had. And that's the neat thing about this is we don't compete with each other. They don't come to Little Rock, we don't go to Mountain Home. So when Ronnie and Leon came down yesterday, they said, can we kind of look your place over? Man, we opened all the doors. I'm happy to open my book since I've seen this many patients. I blew it on this one, and we really did good on this. We developed this protocol. Would you like a copy? I mean, we share that kind of stuff back and forth, and it's wonderful. It's not like hospitals that are in the same town competing, trying to get ahead of the next guy. So that's one really good thing. Let me bring a couple of points home here, and then I'm gonna hush up. I was taking some notes while we were talking. There's a couple of things that we really didn't go over, and that is the cost of healthcare. You guys all know you have patients that you send home, and you know they're not gonna fly. But what can you do about it? Let's call it home health. Just like Jason said, or Gerald said, they don't qualify for home health. Okay, all right, well, this one does. He doesn't want home health. How many of you guys have heard people that don't want home health? And it's just like Jason, I believe, said that they don't want these nice, clean hospital people coming in and seeing how they live because the hospital is so nice. But I will tell you that home health, who we thought was going to be one of our largest concerns, has actually turned out to be one of our best friends because they've learned that we don't want their job. We want to help them connect and do their job. We get calls from home health to say, hey, this guy doesn't want to engage with us. He can, but he won't. Do you mind checking in? They always let the uniform come in because we've been there 40 times already. So they know who we are. Even if it's not me, it's the uniform. So we get in, we make our connection, we understand what the plan is, so we can even start moving that direction. Once we've got that trust built, then we introduce them to our friend from the hospital, let them get to know each other, and then we back out of the way. We've done our part. That's the beauty of this relationship. And that's just one example. Other examples that we haven't talked about that are a part of this are many people call 911 because they don't know what else to do. They know they need something, and they know they don't need an emergency response, but what's their option? I'll call my doctor. What do you get when you call the doctor? If this is an emergency, hang up and dial 911. Well, guess what? Nobody answered the phone. It's an emergency. Okay, so if they had a second option, what would they do? They might dial that number first and say, hey, is this an emergency? Should I or should I not? And we're already seeing that with patients we've engaged that had a direct number they can call. So that has been a big help. When a person calls, some numbers here for you. Okay, the cost from dialing 911, I have a chronic issue that you've seen me for 3 times a month for the last 8 months, but I need you again. Call the ambulance. The ambulance responds. You get there, are you sure you want to go to the hospital? Have you seen your doctor? I can't get a hold of my doctor. Okay. If they want to go, we're going to take them. And we're not going to abandon somebody. So then they get to the ER. What happens in the ER? You can't go to the ER without what? Getting examined by a physician. That physician's not going to just blindly say, oh, you look okay to me. They're going to have to do what? Some x-rays maybe? A little bit of lab? Okay, now you got a radiologist involved to read the x-rays. Now you got maybe a pathologist. At the very least, you've got some expensive lab work done. And now you're tying up an ER bed, but you folks that work in the ERs, you don't have a problem with that, do you? Okay, so you get this guy in the ER bed now for several hours, and then along about 4:30 or 5 o'clock in the afternoon, the ER doc is like, we could probably let this guy home. Hey, doc, we got your patient here. He's been in here before, blah, blah, blah. We're, can't really find anything, but he's complaining of this. Just put him in overnight. I'll see him in the morning. It's too late today. So now you get an overnight admission. Anybody want to guess what those charges run up to right there? About 10.5K. Now, if that same person calls and dispatch can say, hey, Mr. Jones, is this that same back problem you've had for the last 3 times a month for the last 8 months, blah, blah, blah. Let me send Gerald out there with one of the guys to take a look at you. Would that be okay? Or do you really need to go to the hospital? No, I think if they just come and look at it, we can decide. Now, you've avoided all those other charges. You've not tied up an ER bed. You've not tied up a bed in the hospital that chokes the hospital discharge process that goes all the way back to backing up the ER. And now you don't have a patient that you're discharging from the hospital that within 30 days is gonna have that same problem you come back. You've avoided all of that, and guess what? You saved a bunch of money in the short run. So, that's just one example of how community paramedicine really can fit in. The other is, how many of you folks here do case management follow-up stuff? Okay. And your patients always tell you exactly how it is, right? They tell you the truth. No, come on now. They don't ever say, I'm doing fine, I haven't gained any weight with my CHF. Exactly. So, that goes on, but how about if when you discharge that patient who doesn't need home health, they have the clinic they can call. But if you're suspicious, you say, let's just do a quick community paramedic consult, drive-by, whatever you want to call it. And Jason over here drives up. He walks in, hey, Mr. Smith, clinic asked me to come by, make sure you got settled in, everything's okay, hospital stay was good. Oh, yeah, how are you doing? How's your weight? Oh, it's just perfect. Hey, guess what? I've got a scale. Why don't you step on it? Let's see. Or let's try on your Sunday shoes and see how they fit compared to last time we did this. Those are the kind of things that you can't do in the hospital, you can't do in the clinic, and you don't have any way to leave all your other patients to go see this one. So this is the thing that puts your eyes and your hands on your patient and gets you direct feedback, because guess what? We aren't taking the patient from it. We don't want that. We don't want to carry a patient load. We want to fill in where that patient has needs to keep them from backsliding. And once we've stabilized that with you, we loop it all back to you. You're still in charge. And then at some point we say, okay, this patient's graduated. In some cases with your high utilizers, and your 30-day readmission, and we even do little graduation packets and ceremony things. One little statistic I'll leave you with, just to give you something to think about. When we started, it was just me getting started and rolling with it, but I started getting calls from medics that had immediate need patients. So I put on my nursing hat, because we didn't have any community paramedics yet, we were still building. And I'd go see this patient, and I would intervene and do what I could, and we would take care of certain things. And that went on for a little while. Finally, we got our medics through school and got to working with them. Building data in this is kind of a slow process, because the long-term outcomes are what you're looking at. I was very surprised. I was hoping that we could have a 40% impact on our frequent flyers. We used MEMS data. Who's calling the ambulance a lot? Those 222 calls and that kind of thing. We picked those patients. We put them on our list and said, this is where we're going to learn how to do this. We aren't going to offer it to the hospitals till we know what we're doing. So we started in on our own patients, and there were plenty of them. And as we went through them, every one of them we would document. And we finally got enough time and enough patience that we could look back 6 months after discharge from our service and compare that to the 6 months before we engaged with that patient. And I thought if I got a 40% impact on those patients, that would be the equivalent of adding another 1.5 ambulances to the street every day that was not tied up on something that was inappropriate. My assistant ran all the numbers, and on our first 90 patients or so that we did, our high utilizer, he said, hey, we've got a 67% decrease. I said, no, you did your numbers backwards. You really have a 33%. He said, no. I said, give me the numbers. I ran them. I was shocked. For one facility that I just ran the numbers on just for them, we went from, with 16 patients that had comprised 111 calls, 6 months afterwards, 44 calls. It works. If you just have a little surveillance and you have somebody that they can contact. So, is there any points I didn't make, guys? I know we ran over, and I'm sorry. Do you have any questions? We're here. Yes.
Are you feeding that data back to the quality staff at your hospitals?
Pardon me now?
Feeding that data back to the quality staff at your hospitals?
We are, and I will just briefly tell you, the only reason I'm feeding it back to them is because I want them to business, because right now, every dime that we've spent has come out of Mem's pocket. And I will just tell you that we're probably closing in on $1 million investment in this, just for in our community, but no guarantee anyone's ever gonna say, hey, Ed, that's worth something, we want that. But when the doctor calls and says, I don't want this patient to backslide, I want you to watch him for 30 days, I can now say, what's it worth to you? And then we can come up with a price. For 30 days, this much money, I will work my best to keep him out of the hospital. We don't, I'm not gonna get into all the pricing structure we're coming up with, but basically it's, we'll take this engagement for this amount of money. If I have to see him every day, we do. If I see him once, hey, I've made a lot more money per patient. But it's one set amount, and you do what it takes to take care of that patient. That data does go back to the hospitals, and that's what kind of takes a little while. These guys have the hospital numbers behind them that really had fed into the need. Like 30-day readmission was one, obviously the CMS paid for it. But they already had an ambulance service, and they could make that leap a little bit easier than me as an outside contractor coming to you and saying, hey, buy my service and I'll make it better for you. They're in a position with hospital-based ambulance services to actually understand it a little better, because they see the paper trail through the system, and they see what it costs them.
Because I know I haven't received anything, but I don't know if anybody's trying to feed information back.
Hospitals within our service area we're contacting. Let me just say one thing. Amanda Kelly from Conway Regional was probably one of my very first ones, and I went to Walker Story on there. She heard me talk at one of the ACT things when we first started. She and I started talking, and she just called me out of the blue and gave me that, I got this patient, what is it? She said, he's a veteran, but he won't go to the VA because they're all foreigners and they're trying to kill him. So, that's what she said. And so she said that we've had the nurses out there. I've gone to see him. She said, we've kind of hit our limit. Do you mind going to see him? Sure, I'll go see him. I don't know if they have the nutritionist out there yet or not, but it was really enlightening. It was learning for me. I drove up. He's outside with his oxygen in the carport, walking along. And I get out of the car and I say, hi, Mr. So-and-so. Amanda sent me out here and asked me to have a visit with you. Did she call you? Yeah, she called me. And don't you tell me to quit smoking. And I said, I'll tell you what, I'm not going to tell you to quit smoking, but I am going to recommend you don't have your oxygen on while you're doing it. And we started with that. And a few minutes later, we were talking. I wasn't trying to fix everything. I was trying to address what he needed. And when we said something about his CHF and his COPD, and he showed me what I said, well, we probably need to talk to a nutritionist about getting some of the salt out of your diet. He blew up. He said, why? He says, I don't care about my diet. I just want my legs to quit swelling. Why does everybody always say when you talk about my diet? I don't care about my salt. I just want to be able to keep my legs from swelling. And that told me that no matter who told him what, he's not getting it. So we started that. And I got it back to Amanda, and they had a great relationship. It was very fulfilling, very non-frustrating for somebody who was used to short-term contact, and maybe one that was used to being in the hospital, to be able to go in the home, see what they're living with every day when you send them home, what they want to do. Thank you, guys. We hope that if you have any questions, you'll be happy to call any of us. We've got our